I don't see anybody else walking in, so I'm just going to go ahead and start. My name is Lynn Cronin, and I'm a cardiologist here in the Holland area. I work for West Michigan Heart. I've been here about 11 years, I guess, so far. And I've given, a handful of these talks over the years, and I really enjoy it. And I tend to, if any of you have been in my office, go on and on with the talking. It's easy for me to get rolling. That's why I'm always late. And I always, the best part of these lectures is, for me, the questions at the end. So I absolutely invite them. You start thinking about stuff you want to ask. I'll make one request that they not be too terribly personal about symptoms that you might be having, because that's not appropriate necessarily in this venue. And as my 12-year-old son would say, it can be awkward. So I'm happy to tackle any sort of general question, but if you have specific, symptom type stuff, that this might not be the best setting for that. So I'm going to talk about, since it's Heart Month and Women's Heart Month, and we're all wearing red, and most of us, that's going to be a main focus of the talk, but virtually everything I'm talking about, I'll tell you a deep, dark secret here, it applies to men as well, unless we're talking about hormones and things. Men have those too, but they're different. So it's very relevant to men as well as women. I see a good number of men here in the audience, and we're happy to have you. And we're going to focus on both. We all have hearts, and they all do naughty things to us from time to time. So I'm going to try to cover this in as much of a generic fashion as I can, singling out the things that are important to women as appropriate. So we're going to get started. I have very, very few, if any, graphs and number type slides, because nobody really wants to hear about statistics too much, except in a very broad sense. So I don't have a lot of graphs and scary looking arrows pointing up and down and things. We're going to talk about a lot of definitions of what heart disease is. What do we mean by heart disease? Because I get that question a lot, even from patients who have heart disease. They're not sure if they have it or not. And we'll define some things and speak of some things that are pertinent that might not be in your everyday conversation or things that you hear about on television or the radio or in your reading. And again, please ask questions at the end. I'm very, very happy to tackle them. I love to draw pictures. That's my favorite part. I'm going to try to leave plenty of time for that. So without messing around any further, I'm going to get started. So we're going to talk about heart disease, and it has many manifestations, because our hearts, as simple as they are, they're also very complicated. They have lots of moving parts, and it's a humble muscle for the most part, but lots of different things can go wrong with our hearts, and I want to kind of take you through a little bit of all the different things that can happen to our hearts, including some of the names you'll see here. Heart attack, everybody wants to talk about that. That's always front and center in the consciousness and what we talk about in terms of risk for heart disease. But these things, atrial fibrillation, what is that? What does it mean? It's huge. It's an enormous part of my practice, and it's an enormous problem for a lot of people, especially in our older years. Congestive heart failure. Everybody's heard that term, but a lot of people don't really know what it means. And what do we mean by congestive heart failure? Can you have congestive heart failure and then you don't have congestive heart failure? Is it temporary? Is it permanent? My grandma had it. What does that mean? We'll talk about that a little bit. Little stranger disorders that we don't talk about as much in the public, but we deal with a lot, and we'll get into some of these things. We're going to talk about risk factors for heart disease, the kind that you can do something about, the kind that you really can't do anything about, and why we focus so much on the former. Sort of establishing a dialogue with your doctor if there are certain concerns that you have. Maybe I can help you to speak the language a little bit, or give you some suggestions on communicating effectively with doctors. We're not always good at that. And like I said, basically leaving a lot of time for questions. I'm not going to hash over the same thing, hopefully, over and over here. So this slide is a little bit more focused on women, but it happens to be true about men, too, that heart disease is our number one killer, hands down. All cancers combined take second place in terms of risk of what kills us is heart disease, right? Cancer's bad. Cancer's terrible. Cancer gets a lot of attention as a killer, and it's a terrible disease, but so is heart disease. And that is how most of us are going to exit this world. Hopefully not before our time. That's kind of the goal is not to live forever. None of us is immortal. But we are going to do our best to, identify these heart problems and see if we can't minimize the risks in a reasonable way, okay? Just having a healthy heart is a blessing and something that we're all, generally, not all of us, but most of us are born with, and we try to keep it that way, because to have a heart that's damaged or impaired or giving us problems, it can be an everyday burden, can be something that affects every part of our lives every day. And it's, it makes us go, all right? It can be the cause of multiple trips to the hospital, heart surgeries, complications, having to live with a million medications, a million trips to the doctor, testing, blood testing, terrible medications that don't make us feel very good. We get that. Those are our weapons. Those are our tools. It's so much better to not need those things. And that's why prevention is going to be a big part, hopefully, of what we wind up talking about tonight. Okay? We can prevent a lot of heart disease. We can't prevent all of it. We can't keep from getting older. In fact, we encourage getting older. We can't keep from being exposed to some things that are not good for us. We can't help our genes in particular. We can't choose our parents ahead of time. I don't think I would have chosen anything different for parents, but my dad had a heart attack at 50 and my mom has a cholesterol of 600, so thanks. But they're still okay. All right. We don't cure very much heart disease, right? You don't hear cardiologists talking about cure very much. It's a word that we use. I maybe once a week will say that word in passing to somebody. It's easier to cure leukemia than it is to cure most kinds of heart disease. We don't cure it. We manage it. We handle it. We patch it up. We make things better. But there are so very few things about the heart that can be cured. Some things, but tend to be minor things. And so it's not an all or nothing thing. We can't take someone with heart disease and cure them. You can do that with more cancers, actually, than you can with the typical kinds of heart problems. So you won't see us selling you any cures, because we don't have very many. We try to prevent. And when it's too late to prevent, we try to manage as best we can. Okay? All right. So it's preventable. We need to know what the risks are. We need to know what some of the signs are. But even taking a step back from that, we should understand what we're talking about when we're talking about heart disease. If you have it, you may know a lot of this stuff already. But if you don't and you're curious, the heart's a pretty interesting thing, and I want to educate you all a little bit about it. Okay. So the heart has a bunch of moving parts, right? It's a muscle. Its job is to pump the blood around our bodies, right? That's it. Very humble, very simple. It's built for the job. It's beautifully designed. But it's got more to it than muscle. It's got electricity, right? It has to run on a rhythm. It runs on an electric current, just like most of our bodies do, which is not under our control, right? It has valves that open and close that make the blood go in the right direction, right? It has plumbing, right? It has to get its oxygen and its blood supply from somewhere. And it has a lining, and it has a sac and a place where it lives. And all of these things are vulnerable to disease, right? And I'll introduce you to those things a little bit one by one. But the thing we talk about the most common kind of heart disease that we spend most of our time talking about is, I'll put it in plain English, blockages, right? Clogged arteries. Atherosclerosis is the big fancy doctor word for it. Hardening of the arteries is an old-fashioned word, which is sort of, not really accurate, but people get it. It's plaque. It's buildup of cholesterol and gunk and stuff in our arteries that make them too small to carry enough blood to the heart muscle, okay? Heart muscle is very, very efficient. It doesn't need a lot of fuel to run when it's idling, when it's just sitting here like all of us are. But when you're trying to be active, it needs a lot of fuel, okay? And those coronary arteries, the little pipes that supply blood to the heart itself, for some reason, are very vulnerable to getting clogged up. We have arteries from head to toe, miles and miles and miles of them. And you could look at the arteries in your hand, in your forearm, in the back of your knee, inside your brain, inside the wall of your chest, and none of them will have any plaque in them, but your heart will. And that's something we don't understand very well. It's probably because the heart doesn't take a rest very often. It's running all the time. It may have something to do with evolution. Who knows? We don't know why the heart is particularly vulnerable to clogging, but it is. Other areas can get clogged up too, right? The carotids can get clogged up. The aorta can get clogged up. The major arteries in the legs can get clogged up. But these are gigantic things. The coronary arteries are 3 or 4 millimeters in size on average, which is pretty darn tiny. It's about 1/4 of an inch. And the corresponding arteries in our body elsewhere that are that size almost never get clogged up, but the heart does, which is a shame because it's really tough on the heart. Okay, so clogged arteries cause heart attacks, right? Angina, right? A lot of other symptoms that are related to that, and can be the cause of things like heart failure, weakening of the heart damage, all these terms that you hear, which we'll talk about in more detail, okay? So we're going to spend some more time on that. I want to talk about the heart valves, about the lungs and their relationship with the heart, and we're going to spend, quite a bit of time on this atrial fibrillation here because it's a huge, huge problem, and one of the major causes of stroke, which everybody's afraid of. Right? Okay. So our hearts do their thing, and they are on their own, and they function very well normally. And if we get heart disease, we also have to consider how other diseases in the body affect the heart. Things like diabetes, right? Everybody knows diabetes is bad. Well, why is it bad? Well, from the heart standpoint, diabetes is bad because it causes the acceleration, the speeding up of the process of hardening of the arteries, right? The exposure to all that sugar and insulin makes heart disease show up much, much, much earlier, even in the 30s. I have patients in their early 30s, diabetic, who've had their first heart attack, okay? That's very, very unusual. Normally we don't, obviously see people that young having heart problems, okay? So diabetes and smoking are just the worst things for our hearts, okay? High blood pressure affects the heart, right? Because the heart has to work much, much harder when it's dealing with all that pressure. People think that the heart is what causes high blood pressure. It's not. The heart has very, very little to do with the production of our blood pressure. That's under the control of our kidneys, our carotids, and our blood volume. So the heart doesn't cause high blood pressure, but the heart can suffer as a result of high blood pressure because it makes the poor little muscle work harder, right? It can cause the heart to thicken and enlarge, and is a really common cause of heart failure. All right? It can also cause atrial fibrillation. We'll talk more about that. Kidney problems, directly related to heart problems because people have trouble controlling their blood pressure and their fluids, and so they're related. The lungs and the heart are next door neighbors. What affects one often affects the other. And so lung problems can drag the heart down with it, and heart problems can drag the lungs down with it. Also, if you think about what kind of symptoms people get with lung problems, they're short of breath, right? Shortness of breath can be the heart, can be the lungs, can be both, can be neither. That symptom is so common that it forces us to think about the whole picture when we see symptoms like that. Other problems can affect the heart: lupus, autoimmune disease, blood clots, things like that. I'm not going to dwell on that too much. Again, I want to leave lots of time for questions, so I'm going to go a little bit faster through that part. All right, so back to hardening of the arteries. You've probably all seen slides like this and gross pictures of things building up in heart arteries. But this is, if you picture one of the arteries around your heart, a healthy young one, that's just a nice pink healthy tube, right? But imagine it's 1/4 of an inch. These things are so tiny, and our lives literally depend on them. When plaque starts building up in the arteries, what happens is the lining of the artery, which is this very delicate thing, it is attacked and poisoned by the things that we put into our body, things that we're exposed to in the environment. And this lining becomes porous and ragged and unhealthy. And the body's response to that is to picture it as an injury. It says, oh, you poor little thing, let me patch you up. Well, it patches it up with whatever products it has lying around. And that oftentimes is cholesterol and cells that cause inflammation, which if you skin your knee, you get that gook forming on there, that crusty serum stuff. Well, that's almost the same thing that happens on the inside when the lining of the artery is damaged. Your body tries to heal it, right? Except when it does, if there's too much cholesterol and stuff floating around, it winds up healing it, but by putting a layer of junk down in there. Okay, this is the beginnings of plaque that we can see even in teenagers. Okay, autopsies on kids killed in Vietnam in the wars showed these plaques in their arteries in their early 20s. Okay, so this is the body's kind of not very smart way of dealing with injuries. Well, what injures the arteries? Not much in our younger years, but a lot of the stuff we do to our bodies is very harmful to the arteries. Cigarette smoke, it's poison to the arteries. It's not the nicotine so much. It's the junk, the carcinogens, that awful chemicals that you inhale that are just very, very toxic to the arteries, okay? A diet that's high in fat, okay? Fat, when it's metabolized by the body, when the body tries to distribute it and figure out what to do with it, does to the fat something called oxidation, which makes it very noxious and toxic to the arteries. So a diet that's high in fat will put a lot of these nasty things into our bloodstream, and the body doesn't quite know what to do with them, so it shoves them into our coronary arteries where they don't really belong. High blood pressure is damaging to this delicate lining of the arteries because it stretches and pulls on that artery and makes it weaker. Okay? Diabetes is toxic to the arteries because the sugar gets in there and does damage underneath the lining of this artery. Just getting older, unfortunately, well, they're not as springy and healthy as young ones, just like, the rest of us isn't as springy and healthy. Our arteries aren't either. And to some degree, there's a genetic factor here, too. If your whole family had premature hardening of the arteries, everybody had a heart attack in their 40s and 50s, you could probably wager that your arteries were not built to last 100 years, right? So to some degree, some of this is an age-related process. So the unhealthy lining here gets kind of ragged and torn up, and you start building up scar tissue, cholesterol in there. And that's the body's best defense to what it perceives as an injury, but unfortunately it takes up space, right? So you no longer have all this room. You've kind of healed up these little ruptured areas with plaque, and now you have half the space left. So that's the process by which our arteries slowly clog up. And if that happens gradually and gets beyond a certain point, that can lead to something that we call angina, heart pain, difficulty when people exert themselves and they say, my chest hurts, or I can't breathe, or I'm having trouble. And they get a stress test or whatever evaluation they get, and they wind up being diagnosed with blockages, and they have a stent or a bypass or something like that. That's what we're treating with those things. Stents and bypasses are meant to either get around a blockage or to kind of push the junk out of the way and make the artery a normal size again. A heart attack is kind of that process accelerating all at once. Instead of taking years and years for plaque to build up slowly, what sometimes happens, I'm not sure how well I can see that slide, is that plaque has been sitting there for a little while. And for one reason or another, and we don't really understand why on any given day, one of these things decides to tear or rupture, but that's what happens. And now instead of maybe a 50% blockage that's just sitting there minding its own business, planning on taking another 20 years before it causes problems, well, now it's gone from 50% to 100% because it tore. Okay, we call that a ruptured plaque. And it's a lot like a volcano, right? You got a volcano sitting in your backyard. You might know it's there, right? And you hope it lays dormant. But if one day it decides to erupt, you've got problems, okay? Why that happens on any one given day, again, we don't know. A lot of heart attacks just come out of the blue. People feel perfectly well, and bam, all of a sudden they're having symptoms. You've all heard stories of people shoveling snow, and it does happen. Increased stress on the heart can cause one of these to tear. That's why we're not wild about our patients with this kind of problem shoveling snow. But most of the time it's a dark horse. It's something that just happens suddenly. Can happen day or night, and people can feel perfectly well, and boom, they're having a heart attack. Okay. What happens when the artery tears is the body says, oh, now we've really got a problem. It's torn, it's bleeding. What do I do when I'm bleeding? I form a blood clot, okay? And so smart body, but not very smart in this situation. It's try to keep you from bleeding. Well, the opposite of bleeding is a blood clot, and the culprit of most heart attacks and strokes is a blood clot in the wrong place at the wrong time, okay? So that blood clot fills up whatever space is left with a big glob of clot. Again, just like what happens on your knee when you skin it. And suddenly there's no blood getting through here, okay? The heart can survive with even a trickle of blood. You might not feel too good, but it's going to survive. If you cut off that blood supply, that muscle's being starved and will very quickly start to die. Okay, that's a heart attack when the muscle is damaged to the point of actually dying from being cut off from its blood supply, okay? What's the first thing we do when we suspect someone's having a heart attack? What do we give them in the ambulance? Aspirin, right? What does aspirin do? It's a blood thinner, right? And we're not making the blood thin like water, but we're reducing its likelihood of forming a clot. Is it too late? No, it works. It helps, right? Can you dissolve a blood clot with aspirin? No, not very well. In the old days, when I was training, the treatment for a heart attack was to give clot busters, right? Streptokinase and TPA, and some of you may have had that, and I've seen it plenty of times. In fact, it is still out there. It is still okay to use that for a heart attack. We do a lot better with stents and things, and I'll go into that. But those would literally, like Drano, they'd dissolve that blood clot, right, and break it up. And in about 3/4 of cases, would open that thing up very nicely within a couple of hours. That's great. That's way better than sitting around and doing nothing, which is how my dad's heart attack was treated in 1972. They put him in bed and they gave him the last rites and they said, you're having a heart attack. Tell us if it hurts, we'll give you morphine. You may not live. And that was the modern treatment of a heart attack in 1972. I've gone through his records. It's appalling. But they didn't have anything else that they could do at that time. He survived, but barely, right? And he was in the hospital 6 weeks, right? We send people routinely home on the second day after a heart attack now with a Band-Aid and a bottle of Plavix, right? So it's gotten a lot better. So the clot busters worked pretty well, and they still do, and they'll break up that blood clot within a couple of hours. A couple of hours is a long time to have damage going on in your heart. We're talking minutes are crucial. And if you've ever had a heart attack or heard people who've had a heart attack, what we try to do now is identify these very, very quickly and get these people to the cath lab where we put the catheters up through the leg and into the heart, put a balloon down there and push that stuff out of the way, put in a stent and make a new opening, a new channel. And we can do that really fast and really successfully. And that's the kind of modern day treatment of heart attacks, okay? So where does all this stuff go when you put in a stent? That's a common question I get. It just kind of gets pushed out of the way. The stent is metal and forms its own little shape, right? And the blockage is just pushed out of the bloodstream and off to the side. And the body can heal and remodel itself. If you've ever had a lump or something removed, your body kind of fills in and it can heal that up. Is it easy? No. Is it successful? Yes, it's incredibly successful. The mortality, the death rate from a heart attack now is, something like less than 1% for a reasonably young person. Whereas when, 1972, that's 40 years ago, 50% with a big heart attack. So it's helped a lot to change the face of heart disease, but the disease is the same. We're just getting better at treating it. Are we preventing it? Well, we'll talk about that a little bit, okay? All right. So bypass surgery is done, again, if you have lots and lots of blockages and they don't know, if you can't put in stents everywhere. What they'll do is take veins out of your leg and reroute the blood around the blockage. Leave the blockage be, but find another way for the blood to get around using new blood vessels, right? Did we cure anything by patching it up or putting in a stent? No. Person still has heart disease. They may feel a lot better. We may have saved their life, but we didn't cure them. Even the pills, the 1,000,001 pills that we use, don't cure, but we manage. Untreated blockages, disease from blockages that causes a lot of weakening of the heart or damage to the heart from a heart attack. When I was first starting my training in the early 1990s, it was a known fact that, and there might be people in this room who were alive and had this problem back then and may have been told this. It was a known fact, and this is 20 years ago, that if you had a heart attack or multiple heart attacks and damage to your heart, your 3-year survival was about 50%. 50. That is worse than colon cancer, worse than a lot of kinds of lung cancer, just from having had a heart attack and heart damage, because we didn't fix it. We didn't patch your heart up. We didn't save any heart muscle. You were unfortunate. And the prognosis was terrible, okay? If you were treated, if you were lucky enough to have one of the early angioplasties or bypass surgery or something, the prognosis is much better. But until we brought in the modern medications that aren't so modern, they've been around for decades, until we learned how to use these medications properly, the prognosis did not change, right? Medications have changed this enormously, and people are surviving now that had their heart attack in their 70s, in the 1970s and 1960s, 1980s, and they're doing just perfectly well, even though they have terribly damaged hearts. They're doing fine, right? So the prognosis has been changed with medications, and even the people who didn't come around and have their heart problems in the era when we did angioplasty and all this stuff, they're doing fine because of meds. So meds are just as important as heroic procedures. Study after study, in fact, has shown that in people with heart disease, the medications are as important as anything, even more important than stents or bypass surgery, except in the setting of a heart attack. We're not going to sit and give you pills when you're having your heart attack. We're going to give you a stent if you need one. Okay? All right. So, I want to talk a little bit about atrial fibrillation because it's important. It's huge. It's easily a quarter of what I do every day. It's not just blockages, okay? So we're changing gears here to talk about atrial fibrillation, which is an electrical problem, not a plumbing problem, okay? Blockages are a plumbing problem. This is the heart's rhythm. What makes the heart go slow and fast is its own native electrical rhythm. And in most of us, it's normal throughout our lives and doesn't give us a bit of grief. Well, most of us. 1 in 8 people over the age of 70 will develop this problem at some point in their life. It's really, really, really common, okay? And that's probably a whole bunch of people in this room, okay? And even young people can get this. Why is it important? We're going to talk about that. It's really, really common. It's an irregularity of the heart rhythm. I don't have a lot of pictures and diagrams. We can do that later. But basically, the heart loses its normal, steady, metronome-like rhythm and begins beating erratically, irregularly, often fast. That's one of the problems with this, is that the heartbeat can be very fast, 180, 190, 200 beats a minute. Makes people feel pretty sick sometimes. Can also be completely unnoticed by people and be symptom-free. I've found people in atrial fibrillation that you can knock them over with a feather and they don't have any awareness of it at all. It is a very, very variable problem, but it has one thing in common, and that is stroke, okay? The reason atrial fibrillation causes strokes is because when the top chambers of the heart are beating rhythmically, the blood just flows right through. If the top chambers of the heart are beating erratically, which is what atrial fibrillation is, the blood can stagnate in the little pockets, the little corners of the heart, and blood clots can form there. You can see those when you do pictures. And if those blood clots break loose and go out of the heart, the first and second stops are the brain, okay? Make a left and you're at the brain. Make another left and you're at the brain. If the clot keeps going, it might wind up in your foot or your spleen or your kidney. We see that too. We don't call that a stroke. We call that an embolism, okay? But the first 2 stops are brain left and brain right. And when those blood clots break loose, that's typically where they go, okay? It is the second most common cause of stroke, right, after uncontrolled high blood pressure, okay? So, and the third most common cause is clogging up of the arteries here. We're right back to plumbing, okay? That's the same, almost the same disease as happens in the heart. But we're talking here about a rhythm problem. And it's 15% of all strokes are due to atrial fibrillation. Just having atrial fibrillation can increase your risk of stroke 5 to 15-fold. Not 5 to 15%, but 5 to 15-fold. the risks can be really high when you start stacking on other risk factors, and we're going to talk about that. This is another place where we focus on women a little bit. Women got the short end of the stick on this one and are at much higher risk of stroke with atrial fibrillation. That doesn't mean men are not at risk, but women are at higher risk. Okay, don't know why. Okay, just being a woman gives you. I'll talk about the scoring system in a second. Okay. There is a system we use to assess people's risk of stroke with atrial fibrillation. And by the way, how do you diagnose atrial fibrillation? You have an EKG done, right? The simple, humble EKG that most doctors will do in their office. Is it appropriate to do one on everybody at every visit? Certainly not. It's a harmless test, but it doesn't give us a lot of information. If your doctor is listening and checking your pulse and it is perfectly regular and steady, you probably don't have atrial fibrillation. But a lot of doctors will listen when they listen to the heart, say, oh, it sounds a little irregular. That's an appropriate time to do an EKG. People will feel an irregularity in their pulse sometimes, and it's worth bringing up to your doctor. Not if you're 15 years old and you've had too much Coke and haven't slept for 3 days. That's probably not atrial fibrillation. But if you're over the age of 40, let's say, and you're starting to feel a little bit of palpitations or fluttering or pounding in your chest, you probably want to mention that to your doctor, right? And if it's not happening at the moment, of course, when you're in his office, nothing's going to show up. Your EKG can be perfectly normal. But we've got so many ways of monitoring people now that are so much easier than what you might remember 10, 20 years ago when you wore these big, like these things hanging off you all the time. We can do better than that now. It's important to identify this because of the connection with stroke. And it doesn't always cause symptoms, but if there are symptoms, they're generally fatigue and short of breath, and your heart is racing and pounding, and you're not, some people will swear that they feel their pulse and it feels strange. It's worth mentioning to your doctor. It's a 10-second test to do an EKG, and it's worth attention, right? If you're even over the age of 40, it's worth attention. If you're under the age of 40 and you have this, it's worth attention, but it's treated a lot differently. So not everybody is at risk for a stroke with AFib, but a lot of people are, and I would wager almost everybody in this room, except maybe that cute little girl, all right, because their risks start to accumulate and get larger the older you are. And I'll run through some of the scoring that we use for this. When we first identified the link between stroke and atrial fibrillation, it was only, again, about 25 years ago. And that's not that long. Somebody said I looked young. Thank you. But that's my whole career, right? I was in medical school 25 years ago, and this was unknown, this link, absolutely unknown. So in the space of my career, which isn't anywhere close to being done, we've learned a lot. Well, when we first figured this out, we put everybody with this on Coumadin, everybody. Right? Tried aspirin, didn't work. It doesn't. We tried a little bit of Coumadin, thinking, let's just give everybody 1 milligram of Coumadin. That doesn't work either. Darn it, we're going to have to give everybody Coumadin. And we did. And sure enough, some people bled, right? And some people bled who probably didn't need to bleed. And we said, oh, this is ridiculous. We're over-treating this. So the pendulum went from everybody gets Coumadin to nobody gets Coumadin. Let's only treat people who really have it all the time. Nope, that didn't work. People started having strokes left and right. And we swung back the other way. Let's give almost everybody Coumadin. That doesn't work either. Let's give not almost everybody. It's getting better every time, but that pendulum is still swinging because we're still trying to sort this out. What we have now we think is very modern and much better than what we had 20 years ago. And I have no doubt that in 10 years we'll think this is sort of barbaric what we're doing now. That's the nature of medicine. But we give people points based on risk factors, and the more points you have, the higher your risk of stroke. It goes anywhere from a 2 or 3% risk of stroke, which is if you're a 1, to about a 20 to 25 to almost 30% risk of stroke. And this is chance per year, 30% chance per year. That's like Russian roulette. Okay, spin that wheel. And so I'll run it through it quickly, and you can all give yourselves a score. I'm a 1, right? I'm not even a 0 because I'm a girl, right? Any man in this room who's perfectly healthy gets to be a 0. You're lucky, okay? I'm a 1, and if I had atrial fibrillation, my risk of stroke would be approximately double a woman my age who didn't have atrial fibrillation. So right there, I'm in trouble, right? I'm a girl, and that's just the way it is. So I get 1 point for being female. We all get 1 point for being female. If you're not a female, you get nothing, okay? And the lower your score, the better here. Hypertension, whether it's treated or not, whether it's perfectly well controlled or not, you get a point, okay? If you're 65, you get a point or older. If you're 75, you get 2 points, right? You can trade one in for the other. If you got diabetes, you got a point, right? If you've ever had a stroke, 2 points, all right? If you have vascular disease, blockage of the arteries anywhere, heart, legs, carotids, you get a point, right? I think that's it. So they rack up pretty quickly. And the old scoring system was a little bit more modest. You only got a point for, heart failure is another one. If you have a weak heart, you get a point for that. The old system wasn't as hard on women, and it wasn't as hard on younger people. But we're all moved over to the new system now. And all those people who were 71 years old, I said, no, you're good. I have to call them now and say, no, you're not good anymore. You got a point. And so based on how many points you have, your risk of stroke goes up, 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 and up, right? The maximum of points is like 9, and those are the people that have like a 30% chance of having a stroke. Anything over 2, I'm not going to do statistics because it's boring and tedious and takes forever. The justification is there for putting people on a blood thinner because the risk of bleeding, which is there with all blood thinners, pales in comparison to the risk of stroke if you're not taking the blood thinners. This is how I spend a lot of my days, telling perfectly nice people who feel perfectly well that they need to take a blood thinner for the rest of their life so they won't have a stroke. It's tough. Nobody likes blood thinners. We don't like them either. Thankfully, we have some better ones now, and I hope somebody will ask questions about those. But that's what we're focused on because strokes are devastating. You can have a small stroke with atrial fibrillation, but a lot of the strokes with AFib tend to be big, nasty ones. And people are more afraid of that than they are of dying. I would be, because there are worse things than dying, and one of which is to suffer a devastating stroke and to lose your independence, right? So it's worth it. I can sleep well at night knowing that I'm, pushing these pills on people, Coumadin, because I feel it's a good thing to do, right? So if there's any question in your mind about that, it's worth talking about. I think this is as important as heart attacks. It's as important as breast cancer and all these other awareness things. Because strokes are bad, right? And this kind of stroke is largely preventable, okay? Where are we at time-wise? Oh my gosh, I gotta hurry up. Okay, so I think I went through some of this, so we'll skip that. So what else can happen to your heart? I think I'll leave that in the questions part. I hope somebody will ask me some really cool questions about valves and things like that. I'd love to tackle that, but I'm gonna start blasting away at the rest of my talk here and leave questions. Let's see. Okay. So how do we handle heart disease? How do we prevent? How do we control heart disease? There's got to be a team effort, okay? I'm a specialist. I see a lot of patients who have heart problems. I see a few patients who don't have heart problems, and I'm happy to see them. They're just worried about it, or their family did, or they want to be checked out, or sometimes people come to me because their chest hurts and it winds up being shingles. Right? We can handle that, but it's a collaboration. Not everybody has a cardiologist. Not everybody needs a cardiologist, but most of us, especially people that come to lectures, are pretty health conscious, and we have doctors, or we have a nurse practitioner, we have a PA, we have somebody we can talk to. It's worth the dialogue. If you're here at this lecture, it's because you're interested a little bit, you care a little bit about your heart. Ask questions of your provider, your healthcare provider, even if it's a gynecologist or something, and you see them once every 2 years for your pap smear. How's my blood pressure? Should I get my cholesterol checked? Yeah, you probably should. Ask about that. What about a stress test? What about things like that? We'll talk about that a little bit more. But you have to have a dialogue. If you have questions, you have to ask them. If you have information that you've read and it doesn't make sense to you, ask for a translation, right? Anybody should be able to provide that. Yes, we're busy and we only have 5 minutes, but we can answer a question. If you can't get an answer, keep reading. Some people make an appointment. I'm not plugging for business at all, but some people make an appointment because they have really kind of hairy questions that they want to ask that are just not easy for them to articulate. They had a weird family history. That's something that happened to their brother my dad had a heart attack at 50, my brother had a heart attack at 50, my uncle had a heart attack at 50, I'm 49. I've seen people like that, right? To be able to answer questions and talk and to open a dialogue is hugely important, and you have to empower yourselves to do that. And if a doctor's not answering your questions, keep asking, right? And we're all busy, none of us have time, but we should be able to do that kind of thing. If you're reading on your own, if you're using resources like the internet and books and stuff, that's fine. Be choosy, be selective. There's so much garbage out there, there's so much nonsense out there. Be discriminating in what you read. Don't believe everything you read, even if it's MD on the end of it, because doctors are human too, and we all have agendas, and we all have pet peeves and this and that. Use good resources like Mayo Clinic and Cleveland Clinic and Spectrum Health, and Holland Hospital has a website. At least start out with something fairly legitimate and be critical. WebMD is good, Hippocrates, eMedicine. There's a lot of good websites out there. I can answer a million questions about that. And read. And if, at least if you go to the doctor and say, I have a specific question, it's a lot easier to handle than, do I have heart disease? Oh gosh, that's a huge question to tackle. Where do you want to start, right? I would need an hour to answer that question. But if you ask, do I have atrial fibrillation? Well, we can handle that. Break it down into a chunk that you want to ask and something that's important to you. Let's talk a little bit about how to be healthy, right? Everybody in here eat a perfect diet all the time? Show of hands. I'm not putting my hand up. Okay. I want to harp on the things that we can control. Okay. You cannot control your genes. You cannot control your age. You cannot control your gender. Anybody here who's my patient has probably heard this speech, okay? We got to focus on the things that you can really do something about, okay? Why do we focus on cholesterol so much? Is cholesterol the most important thing? No, right? Is cholesterol important? Yes. I won't go into it in a lot of detail, but the reason we harp on it so much is because cholesterol treatment nowadays is, for most people, really easy. You take a pill and your cholesterol goes down, right? And the pills are quite safe. Not everybody can take them. There's no question. A lot of people can't take cholesterol medicine. But for those who can, cholesterol is fairly easy to manage, and it's substantially effective in getting the cholesterol down. And if I had graphs, which I hate putting on lectures like this, you would see that the death rate from heart disease and the occurrence rate of heart attacks is going down, 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 and down. And that's exactly when statins started becoming widely used. We can credit statins with reduction in heart attacks and strokes. People are living longer, and it's real, right? But not everybody can tolerate them. What about this? What about that? Those are all perfectly legitimate questions. But the reason we go crazy about cholesterol, 2 reasons. It really works if you can control it, and it's something you can control, right? I can't say let's just not treat all the people from New Jersey because they're hopeless, right? But you can't do anything. You can't help it if you're from New Jersey. I'm from New Jersey. You can treat the things that you have some control over. Okay, smoking. Why is smoking so important? Because it's the worst thing for your heart, bar none. Okay, not to mention the cancer and lung disease and all that other stuff. It is the worst. So I hope nobody here smokes. People that come to these lectures, again, are usually pretty tuned in. But it is the pits. And to be able to get someone to stop smoking, I consider one of the greatest accomplishments. I can probably take credit for maybe 2 people that would give me credit for them not smoking. But you have to do that on your own. It's much, much harder. And there's little a doctor can do to convince somebody. If they don't want to quit, they're not going to quit. But it's so important, so we harp on it. In fact, we get nailed. We get punished by insurance companies if we fail to nag smokers. We do. We get massively punished. So I'm sorry, if you smoke, you're going to get tortured every time, unless you threaten me. And I've got one guy that threatens me. So I ask him if I can do it every other time, and he says, okay. Diabetes is also hugely important. Why do we harp on diabetes? Because, well, diabetes is partially under our control and partially not. You cannot just say, I've decided not to have diabetes, right? But you can control it, and the complications of diabetes are directly linked to how well we control it which is something in our grasp, and also how much time you spend with diabetes, which is not so much in our grasp. But if you die at 35 of complications of diabetes, we've failed, right? Obviously, the patient's life is shortened, right? It's probably because it hasn't been well controlled. So living with diabetes is possible, but very, very difficult, okay? Why do we talk about weight and exercise and diet so much? Well, because they all make a huge impact on these things. And to me, they're so doable. Not necessarily weight. I don't harp too much on people about weight. I'm not as brutal well, sometimes I am. If I think it can be done, I will push people really hard. If somebody is 88 years old, they have 2 bad hips, 2 bad knees, you're not going to see me yelling at them for not walking 2 miles a day, okay? So if I'm yelling at you, it's because I think you have potential. And if I'm not, it's because I like to think of myself as a realist. I'm not going to yell at somebody who can't walk to go out and walk. But diet, I wanted to spend more time on this, and I hate to run out of time for questions, so I'm going to go quick. Look around you and be like me. This is something you can do. Look around you in the grocery store. Look around you in the halls of the hospital. Look around you in the cafeteria. Just walking down here, saw a guy coming in to visit, and his pregnant wife was with him, and they had like 4 boxes of pizza. And they're walking to visit somebody in the hospital and bringing them a pizza. And I think that's just appalling, right? If you're going to eat pizza, do it privately. Or better yet, don't do it at all. People bring in Burger King every weekend when I'm here on call. I'm not on call every weekend, but when I'm here, people bring in Burger King and McDonald's breakfast for their dear loved one in intensive care. And it just breaks my heart. If I put together, I'm not going to grill you all on healthy diet, right? If I put a multiple choice quiz up here, you would all get an A, right? Because we know what's bad for us. We know the bad stuff, fat and sugar and too much, right? That's all bad for us. If you look around and think of things very, very simply and look at what our individual weaknesses are, it's not that hard. I ask patients that all the time. What are your worst crimes, right? What are your worst sins? And people can snap them right out. And everybody's different, right? For me, it's portion sizes. I love to eat, right? I don't so much care about dessert, but somebody else, they love their ice cream or cookies or candy or whatever it is. You've got to be honest with yourself. You've got to be realistic about what you eat and think about it. I could do this for an hour, but in 30 seconds, my advice to people about diet would be brutally honest with what you're eating. Everything counts. Come up with the 3 worst sins, right? Not 7 deadly sins, just 3 is enough, right? And do whatever you can to make those better, right? If it's cake and ice cream, think about how you can make that less. If it's portion sizes, think about how you can do that. If it's fast food, just stop that. It's poison, right? Fast food is insidious and just so terrible for us. But think about it realistically. Don't punish yourself. Don't hate yourself. Just be honest with yourself about what you need to do and do it. How did you lose 40 pounds after you got yelled at by your cardiologist? Yeah.
Instead of like baking fried potatoes every morning, bacon became a treat maybe
Good.
once every 2 weeks.
Yeah.
And potatoes, they're almost not as good as
Yeah.
before.
So it's the thoughtless stuff that we often think, I always have bacon for breakfast. I don't.
Sure came up
But
big time.
yeah. So, whatever it takes, think about being healthier that way. That's what we mean when we talk about prevention, just taking better care of our bodies. And in our society today, a lot of it is what we eat and what we do. We don't exercise enough. We eat too much. I could do another whole lecture on that, and I'd be happy to someday. But I do want to leave time for questions, so I'm going to can it at this point and invite questions. Go ahead.
Can you talk about valves and
Sure.
valve prolapse?
Sure, okay. So I'm remembering. The question is mitral valve prolapse, okay? So I'll give you the 2-minute dissertation on mitral valve prolapse. You've got a ventricle here, a pump, and you've got a chamber on the top, right? We're going to pretend this heart only has 2 chambers because that's what's important. In between the top and bottom chambers is a valve, in this case the mitral valve, okay? When it's open, it lets the blood go down into the ventricle, and when it closes, it keeps the blood from going backwards. It's supposed to go out here instead. Right? There's another valve there. We're not going to talk about him. This is a healthy-looking mitral valve, okay? It opens and lets the blood into the heart, and then it closes and says, no, you got to go that way. You're going out, not going backwards. Okay, blood going backwards is bad. That's why God gave us valves, okay, or Mother Nature, whoever you want to credit. When you have mitral valve prolapse, which is a disorder where you are born with tissue that's too stretchy here. The collagen, the protein that holds the valve together is just defective. It's not good enough to last 100 years. And it starts stretching. Right? It's too floppy and stretchy. And over time, usually 30, 40, 50 years in men, 50, 60, 70 years for women, okay? Men have wimpier valves than women. This valve will start to stretch, okay? Anybody own a pair of underwear that's kind of old, right? The elastic just doesn't snap like it used to, okay? That's what happens to the mitral valve when you have a condition called mitral valve prolapse. Okay, eventually, it's perfectly normal when you're born, perfectly normal when you're growing up, but sooner or later it starts to flop and stretch because the elastic tissue is just not strong enough. And when it does that, it starts to leak, okay, because it can no longer hold itself closed. When the valve starts to leak, the blood starts going backwards, and the next stop from there is your lungs. People develop heart failure from the leaking valve. Oh my God, that's horrible. Sorry. Is it where I'm standing? Okay. No more pictures. So it is actually more common in men than women. Men have fewer symptoms than women. It's kind of a paradox. The typical man with mitral valve prolapse is diagnosed in his 40s, and the typical woman with mitral valve prolapse might be diagnosed in her 20s or 30s. It was very fashionable to look for mitral prolapse 30 years ago when we barely had echo. If it's a legitimate diagnosis of mitral prolapse, typically not until the 60s or 70s that it begins to be a problem for women. We don't know why. But these valves can be repaired beautifully with surgery, taking all the loose tissue and kind of carving out, taking a dart, if you're a seamstress at all, if anybody knows anything about sewing. You just nip and tuck and put the valve back together and you get beautiful outcomes from that. Yes? Oh, dear. What's so bad about smoking? All right, how much time have you got? I do. All right, so here's an artery. Okay, remember that picture I showed you with the cross-section of the artery? This red layer here is called the endothelium. It's one cell thick. And it lines every vessel, every blood vessel in our body. And if you stretched it out, it would be like the size of 4 of these rooms. We have acres of this stuff, all one cell thick. And it is the barrier between our blood and the rest of us, okay? It decides what gets through and what doesn't. It's an incredible organ, all one cell thick. Yeah, right. It's not working. So, smoking. Cigarette smoke is full of all sorts of chemicals. I can't even pronounce half of them, much less spell them. All of which, many of which, I won't say all, are very, very toxic here because the smoke, the chemicals in the smoke are very volatile. They get right into our lungs, which are lined with the same stuff, and pass right through. Okay, and once they're in our bloodstream, they have an affinity. They like to lay out around this layer here. And they're very, very toxic to these cells. It's a little bit like acid rain, right? If you have a car and you leave it outside in the acid rain in New Jersey, the paint gets chipped and pocked and dull and pitted, right? And that's exactly what happens to the lining of these arteries. Can you hear that anymore? Oh, good. Okay. So anytime there's an injury to this endothelium, this layer of tissue, what does the body do? I'm going to heal you, right? I'm going to heal you by sticking a blood clot on that. I'm going to heal you by patching it up with some extra what's a better word than crap? Cholesterol and junk that happens to be floating around in your blood. So if that happens to be a lot of cholesterol or sugar because you're also a diabetic with high cholesterol, guess what? The patching, the spackle that's going to be used is really nasty, unhealthy stuff, right? A 15-year-old who smokes, right, got a very viable, vibrant, healthy arterial wall. But after 20 years of smoking, there's only so much recovering that layer of tissue can do, which is why smoking one cigarette isn't going to hurt anybody, but it's a cumulative thing. The other parallel that we often draw is radiation, right? You can be exposed to a little bit of radiation, right? And you go out in the sun and for 15 minutes and yeah, it's a little tingly, right? But if you stayed out there for 4 hours, you'd be burnt to a crisp. Okay, so that's a cumulative effect. One cigarette is not what does people in. It's the years in the cumulative effect. And just like a sunburn, if you go out the next day and the next day and the next day, you're going to be charred and you can do permanent damage. And it's the same thing. It's the cumulative effect that the body can no longer keep up with. Right? So think of the endothelium, that lining of all of our blood vessels, like your skin. And think of cigarette smoke like the sun, right? It'll burn you up if you get too much exposure. Right? And the healing can happen. You can keep bouncing back, but only to a certain degree. And after a certain point, there's no more healing, and now you're just patching it up with whatever duct tape and glue and stuff that you have at hand. Okay? That's why, a 15-year-old is not going to get heart disease from smoking, but if he or she keeps smoking, at 40 they probably will. Okay? Anybody else? Questions? Sure. Yeah, lots of opinions. Fish oil is really, really, really good for one thing, and that is lowering our triglycerides in our blood, which are a kind of fat that's related to cholesterol. And that's about it in terms of what we have scientifically proven. They do a very, very good job of lowering triglyceride levels, right? Because they sort of enhance the clearing out process, because the fish oil is a kind of healthy fat that helps our body to recognize the bad fat and clean it on out of there. It is touted for a lot of other things, arthritis and inflammation and all of this stuff. It's good for our brains. Yes, all of that is true. We should have this in our diet. Fish is very good for us for that reason. But therapeutic doses of fish oil, 2,000, 3,000, 4,000 milligrams a day, is used to lower triglycerides, and that's about it. Right? It is not very much helpful in thinning the blood or anything like that. But yes, we do use it for triglycerides. Yeah. Yeah. I'll get to you next. It depends on why you're on it. For atrial fibrillation, the idea is to protect someone for as long as you safely can, right? There are other blood thinners now coming out. We've got 3. We had 1, and then we had 2, and now we have 3 substitutes for Coumadin that are available for atrial fibrillation patients that you could ask your doctor about, that are very welcome, right? They're not a panacea either. They have their own issues, but they're a huge relief for people who have trouble with Coumadin. But yeah, the idea is to protect people from stroke for as long as you can, unless they start bleeding or something. And I got one ahead of you, and then we'll go back. Yes, ma'am. Well, if I'll answer the question generally because I don't want to speculate about you, the individual. Strokes, when you can't find the reason, we give that a name, a Greek name called cryptogenic stroke. That's Greek for we don't know what caused it, okay? Studies are showing now that if you go looking for atrial fibrillation in people that had a stroke and you had no idea where it came from, you will find it in 18 to 25%. So about 20% of people that had a stroke, and you said, I have no idea why this person had a stroke. We looked at the carotids, we looked at this, they don't smoke, their blood pressure's fine. Why on earth did they have a stroke? 1 in 6, you'll find atrial fibrillation. So yeah, it's possible. It's possible. Yes? Uh-huh. Yeah. I didn't mention his name when okay, yeah. Yeah, well, coenzyme Q is, I'll briefly, try to be brief. This is something that our bodies make ourselves. We produce our own coenzyme Q, and it allows our muscles to function in optimal fashion, right? And one of many things that we need to keep us going. Can you hear me okay? Because this is not shrieking anymore. So one of the theories, there's two things about coenzyme Q that are sort of buzzed about in the heart world. One is that people who have a hard time tolerating their cholesterol medicine, their statins, may be having that problem because statins slow down the production of our own coenzyme Q. That's a fact. It does. Okay? So the theory there was, let's give people coenzyme Q and replace what they're not making enough of when they take their statins, and they'll feel better. And that was tried, and about a third of people felt better. So some people responded and some people didn't. Is it harmful? Probably not. It's a natural substance, and by that I mean we make it ourselves. It's not really a drug. It's something we have plenty of our own. So to use it for people who have problems with statins is logical. It was not a home run. It didn't work great, but I always feel like it's worth trying, right, if people have problems with their statins. If you're not having problems with the statins, you probably don't need it. We make enough. It's not like it gets cut off, right? So that's worth a try in people with problems tolerating their cholesterol medicine. About a third of them will say, yeah, it helps me a little bit. It's expensive. It's more expensive than the statins nowadays, but probably harmless, okay? The other thing where coenzyme Q is often talked about is in cardiomyopathy, which is a disease of the heart muscle. If we're not sure what caused a heart muscle weakness, especially in children, they tend to be very aggressive about saying, let's try everything, let's use this because it's probably not going to hurt. But the results of that have been very disappointing. It doesn't really seem to help much. So that's what we know about coenzyme Q. It was very promising. It makes perfect sense that it would help people with statins, except it only helps a few. And so that's how we feel about that. I don't have a problem with people trying it, without calling it miraculous, because it isn't. The other time we use full dose aspirin is right after a heart attack or a stent for a brief period of time, and rheumatic fever, which nobody gets rheumatic fever hardly anymore. But everybody else who we recommend aspirin for, we get 81 milligrams, everybody. Even people who've had multiple heart attacks, bypasses, 81 milligrams, because it's safer. It's less risk of stomach irritation.
Does it make a difference what time of the day you take it?
It doesn't. It doesn't. In spite of what's going around on Facebook, some nonsense thing. Yeah. You're supposed to take it this, and you're supposed to drink water, and that's a bunch of garbage. No, the effect of aspirin on your blood is permanent. You take an aspirin, and it paralyzes your platelets, and that effect is permanent. So you can take it any time of day is fine. If you're naive to aspirin, if you've never had an aspirin in your life and you think you're having a heart attack, yes, get it in you as fast as you can. But if you've been taking your aspirin every single day, that effect is stable and permanent. You don't have to worry about what time of day. Right. Who else had a question? Yes? Like, what do I consider normal? 120 over 80. Yeah. Acceptable is 135 over 85 or better or lower, right? For most people, right? Anything above that, with there's always exceptions and people I'll let run higher, but anything above that is elevated, right? If you're 136 over 86 on average, I'm not going to give you too hard of a time, right? But those are the numbers, and it doesn't matter how old you are, right? You had a question. Somebody had a question. Yes, ma'am. Yeah. An ablation with an A is, well, there's all kinds of ablations, but you're asking about atrial fibrillation. All right, so I got to draw a picture. I'm scared to come over here. Dang it. All right. Here's your heart again. I'm just going to put this back on. I'm going to draw all 4 chambers this time. Okay? 4 chambers. Some valves in there, right? This is the right side of the heart. This is the left side of the heart, okay? Most atrial fibrillation comes from up here. You've got 4 little veins in the back of your heart that drain the blood from your lungs. And for most healthy people that don't have atrial fibrillation because they have a hole in their heart or a bad valve, most young healthy people who have atrial fibrillation, it's just coming from weird patches of electrical tissue up here, in the back of here, up in these veins, that are just noisy bits of electrical tissue that have no business trying to run the heart rhythm, but they do, okay? They insist that they want to drive the heart. The normal control of the heart's rhythm comes from all the way over here, one tiny little speck called the sinus node. That's who's supposed to be in charge of the heart rhythm. It knows what to do. It knows when to slow down. It knows when to speed up. It knows when you're sleeping. It knows when you're awake. Bad and good, and goodness sake. This is supposed to be the guy in charge. These over here are rogues, okay? They're just, we don't know why they're there, but it's electrical tissue that suddenly does a hostile takeover of the heart's rhythm, sends out electricity 600 times a minute, and the heart says, oh, okay, I'll go along, right? That's what atrial fibrillation is in the average young healthy person. These crazy patches of electrical tissue here just deciding they need to run the rhythm, okay? When we do a cardioversion, which a lot of people have heard of, when we shock the heart, right, we tell everybody to be quiet for a second with electricity. Shh, everybody just be quiet. And then we hope this guy over here takes back over. Okay, sometimes that works and sometimes it doesn't. If it doesn't, what we do, an ablation, is trying to take these patches of electrical tissue and isolate them. Tell them, be quiet in there. You can make all the noise you want, but we're going to build a fence around you so you can't bother anybody anymore. Okay, you can yell and scream all you want and have your party, but we are building a soundproof fence around you. We can't make you be quiet, but we can allow the rest of the heart to ignore you. So an ablation is literally isolating these crazy, noisy electrical bits of tissue up in here by burning the tissue around them with a little electric tip catheter that makes burns around these 4 openings. The idea being that when you get scar tissue forming there, electricity cannot pass through scar tissue. Okay, so if you form nice scars all around here, the electricity can't get out, right? It's still going on back there. You could put a catheter in there and see it fibrillating away, but the heart won't listen. Okay, so that's what an ablation is. You go in all the way up from the leg into the heart across this membrane here. It's a very elaborate, complicated procedure. And you tediously, slowly, one zap at a time, make burns all around here. It takes hours. Okay, it can take hours. And they have very fancy catheters that help them to map and show exactly where these bits of tissue are. And you scar around them, build a fence so the electricity can't get out anymore. The heart ignores it and goes on with its own rhythm. Okay, does that help? Okay, it's fine. It's the point with the catheter is to get into the heart and get access. You got to go through an artery, right? Traditionally, the old-fashioned heart caths were done through here, brachial artery. Cut it down, surgery, find the artery, stick a catheter in there, stitch it all up when you're done. Tedious, takes a long time. There's a lot of nerves around there. Then we move to the groin because you have this great big huge artery right here on either side, the femoral artery. Easy, and it's still sort of the gold standard. But, you know, it bleeds, and you got to lay on your back for 8 hours. You happen to have 2 very nice arteries here in your wrist, the radial arteries, okay? So it's often been tried with varying success to get up through that artery. It's close, it's short, but the artery is very muscular and spasms a lot. This is why people have cold hands, right? Those arteries clamp down at the drop of a hat. So only recently have we come up with catheters small enough to get in there that won't routinely cause these arteries to spasm down, which can be bad. I mean, it can really hurt. And so we've got such small catheters now to go in that we can routinely do most heart catheter procedures through the wrist. Most. You can't put one in the lungs from there. You have to use a vein for that, and you can't use the vein. You have to have a pretty darn good, strong artery there. You have to have a good artery on the other side in case you mess this one up. You don't want your hand to fall off, right? So about 75% of people are decent candidates for that, and it's operator dependent. So I don't do heart caths, so I don't offer people one or the other. But the people who do, it's becoming a very popular way to do it because the recovery is much quicker. You get a little strap around your wrist, and you're walking around in an hour instead of lying there with a sandbag. Say again? Yeah, you can. You can do a heart attack through. You can do a emergency angioplasty through there. Yep. Yeah, it's pretty cool. All right. So yes, we have 2 doctors here of the 4 who do caths who do those. Yep. Yep. Anybody else? Yes. Not exactly, but for all intents and purposes, for Yes, basically the nutritional value, you're basically getting your omega-3s, right? Krill oil is a little less stinky, tends to not go rancid as quickly if you've ever opened a bottle of fish oil from the vitamin store. Okay, by the way, if you buy fish oil and it smells gross, it's probably bad, right? Keep it in the fridge. It's not going to smell great, but if it smells awful, it's probably rancid, which isn't to say it's poisonous or anything, but it's just not good. It's oxidized. The same thing that happens to the cholesterol in your blood that makes it bad happens to any oil and makes it not so good. So krill oil tends to be a little less volatile and less likely to go bad. But the benefit nutritionally, the omega-3 is virtually the same thing. Yeah. If you think you're having a heart attack, yes, because one aspirin, if you take your aspirin, go to the hospital, false alarm, one aspirin is not going to make or break someone typically who's on Coumadin. In fact, many of my patients are on both Coumadin and aspirin. It's perfectly fine to use them both together if you have a good reason. So yes, I would say default to being safe, take the aspirin, and then if everything's fine, you say, well, okay, good, I don't need to keep taking it. But yeah, you can use the two together, and I would, yeah, sure, yes. Well, it depends on, if it's very recently after the surgery, or you mean it's been ages, and I put no limits on people if they've recovered well and have no symptoms after heart surgery or stents. Obviously you've recovered and it's now been months or years. That's going towards what amount of exercise is recommended for any healthy individual. And that 20 to 40 minutes of getting your heart rate up a modest amount, 5 or 6 days a week, right? Do we allow some variation in that? Sure. Is 7 days better than 6 days? Yeah. But if you got a sore knee and all you can do is 6, I'll take 6, right? I love to see everybody doing 30 minutes 5 days a week. I think that's a bare minimum. And I'm talking walking at a decent pace, enough to get a little sweaty, a little tired, a little out of breath. You do not need to flog yourself to dripping. That's basic health maintenance, right? If you want to lose weight, you got to do more. You got to push it a little bit. But 2 miles actually happens to be about 30 minutes at a good pace. So I think that's about right. But if someone who's had bypass wants to run a marathon, fine with me, right? Train appropriately, be smart, go ahead, right? 30 minutes a day, if you want a nutshell, I think is perfect, right, for most people. The drugs for fragile bones may or may not be all that great for your bones. I don't have an expert opinion on that. There is a lot of talk about calcium metabolism and heart disease and how adding calcium supplements may not be as benign as we thought. As far as the Fosamax family and drugs like that, no, I haven't heard anything compelling about that. But calcium comes up now and then about how women who take calcium may or may not be helping or hurting themselves. Near as I can tell from all the studies that have come out, that going excessively in either direction is probably not good. Taking 4,000 milligrams of calcium a day is probably too much, but taking none at all is not good either. So I think that's the reason we have guidelines, and I stick with them. Anything in excess is probably a bad idea. The specific drugs you're asking about, though, no, I don't have any major concerns about those. Well, it depends on if we're starting with a blank slate, you have no complaints, you feel perfectly well, then we'll focus on, what are your concerns, what are your specific questions. I don't have a stock set of tests that I order on people at all. In fact, I have people I see for years and years and years and I never do tests on them. I'm not a big tester. I respect tests, they're very helpful, but I have to have a question before I go looking for an answer. So if you feel perfectly well, I might not do any tests, right? Yeah, those are okay. Those are sort of geared at, are you at increased risk? Are you at higher risk than the average person your age for having those things? I think that's a good place to start a conversation, and it often will go into how's your cholesterol, how's your blood pressure, how's your diet, how's your exercise. It's a good place to start a conversation. I don't order a lot of those tests myself. I think you can get the same information by asking questions. Do you smoke? How's your blood pressure? What's your family history? How's your cholesterol? I don't think those are terribly helpful to me, but to patients, to people who might not even be patients out in the community, if it gets you paying attention and talking to your doctor, they're a good tool. right? Yep. Your genetic, smoking trumps genetics completely. If people say, my whole family has heart disease, if they were all smokers, you really can't say if that's a genetic thing or not. So in a whole family of non-smokers, you're more likely to take after your family if you're a non-smoker. If you're a non-smoker in a family of smokers, you can't really compare yourself, right? If you're a smoker in a family of non-smokers, you can't count on those good genes. So genetics are most accurate when there's not a lot of smoking going on. So if you've got long-lived parents, you're probably in good shape in that regard. Remember, too, that in the 1930s, 40s, 50s, we didn't do much about hypertension. We didn't know a thing about cholesterol. We didn't do a very good job of prevention. So people that lived into their 80s back then might have been walking miracles. They might have been walking around with blood pressure of 190 for 20 years, right? Back in the 60s and 70s, you asked about blood pressure, what's normal. Back then it was 100 plus your age. That was normal, right? So if you're 75, 175, you're fine. That is a fact, all right? And it's because untreated, that's kind of what we see. Our blood pressure creeps up as we get older. So we do so much better now. My parents were much older when I was born. I'm not even in the same era as them. My mom's going to be 90. She's fine, right? I feel good about that. But we never took care of people the way we do now. So it's hard to extrapolate too much about genetics because so much has changed in how we look after people. I think for the better. Yeah. Oh, the Southern diet. That's so unpopular now. Did you see the thing in the news about the Southern diet? Oh, you got to look it up.
Is there a possibility that has a whole lot of effect on it, or can we help ourselves with our diet?
You look up in a search engine, you Google Southern diet and stroke. It just came out this week that there's a gigantic correlation there. Is it anything more than just a collection of habits that people have? Probably not. Just being from the South, if you're a vegetarian, you're probably okay, right? No, right, yeah. Yeah, see, I'm Italian, and we eat nothing but olive oil and tomatoes and stuff, so I'm probably going to live forever. It's never too late. Oh, yeah, it's never too late to turn things around. Yeah. You can stop heart disease. You can't go backwards very well. You can stop it in its tracks, and if it's only a little bit, you can live a long, long time. If your heart is too slow, that is 95% of pacemakers are when the heart beats just too slow, okay? Sometimes we use pacemakers to force the heart to slow down, which sounds a little odd because we do an ablation, a different sort of ablation to force a heart to slow down, and then we need a pacemaker to help us out. Sometimes special kinds of pacemakers are used for people with heart failure to make their heart beat more efficiently. But the standard usual pacemaker that people get that you hear about your aunt getting or your sister or your brother or your cousin is because the heartbeat is too slow and people are feeling bad because it just isn't going fast enough.
Well, I know a little 93-year-old lady who makes a bed every day and is breastfed each morning, and I think I would like her pacemaker.
She wants her, yeah. You might want to steal her heart while you're at it. 93-year-olds have remarkably good hearts because if the heart's going to get you, it's likely to get you long before you're 93. We see very few bad hearts in 93-year-olds. We do see them, but you'd be amazed at how many 90-plus people have really good hearts. Yeah, they just passed that whole point in their lives. Last one. Sometimes, if you're just not getting anywhere. Actually, nephrologists, kidney doctors, and heart doctors wind up being the specialists that tackle a lot of hypertension. Sometimes, if you really, yeah, I see people for uncontrolled hypertension all the time. I'll tell you, 9 times out of 10, I wind up taking away medicines from them and changing things because I tackle it on other levels. How much salt are you eating, right? Are you popping the Motrin like they're nothing? Okay, Motrin and Aleve and all those things are absolutely horrible for your blood pressure. We talk about lifestyle a lot of times, And I ask people to keep really good diaries of their blood pressure, and I like tackling blood pressure. It can be really challenging, but a lot of times the answer is not just here's another pill, although sometimes it is. It's really not a singular thing. It's a very individual thing. You got to think about the salt, though. In 90% of cases, that's just not being dealt with well enough. Right? Salt is a huge issue. I wish I had another hour for salt. Okay. All right, one more. Of course. Sure I do. All right. But not right now. I want to go home. Maybe tomorrow. All right, thank you.